Keratitis. Introduction. Keratitis is an inflammation of the cornea, the transparent front part of the eye that covers the iris and pupil. It can result from infections, trauma, or underlying conditions and may lead to pain, reduced vision, or even blindness if untreated. Keratitis is a significant public health concern, particularly in contact lens wearers and regions with poor sanitation. Prompt diagnosis and treatment are critical to prevent complications such as corneal scarring or perforation. Definitions. Keratitis is an inflammatory condition of the cornea caused by infection, injury, or other factors, often presenting with pain, redness, and impaired vision. A potentially sight-threatening corneal inflammation triggered by microbial agents, trauma, or systemic diseases, prevalent in both developed and developing settings. Risk factors. Infectious factors. Bacterial infection, example Pseudomonas aeruginosa, Staphylococcus aureus. Viral infection, example herpes simplex virus, varicella zoster virus. Fungal infection, example Aspergillus, Candida. Parasitic infection, example Acanthamoeba. Non-infectious factors. Contact lens overuse or poor hygiene. Eye trauma, example scratches, foreign bodies. Dry eye syndrome or eyelid disorders. Autoimmune diseases, example rheumatoid arthritis, Sjogren's syndrome. Environmental and lifestyle factors. Exposure to contaminated water, example swimming, showering with lenses. Use of expired or contaminated eye drops. Poor sanitation or hygiene practices. Prolonged UV exposure or chemical burns. Occupational hazards, example welding, agriculture. Etiology. Keratitis is classified based on its underlying causes. Infectious keratitis, caused by bacteria, viruses, fungi, or parasites invading the cornea. Non-infectious keratitis, results from trauma, chemical exposure, or sterile inflammation. Mixed keratitis, combines infectious and non-infectious elements, example trauma followed by bacterial infection. Types. Bacterial keratitis, rapid onset, often linked to contact lens misuse. Viral keratitis, chronic or recurrent, commonly due to herpes simplex virus. Fungal keratitis, slow progression, associated with plant-based trauma or rural settings. Acanthamoeba keratitis, rare but severe, tied to water-contaminated contact lenses. Photokeratitis, non-infectious, caused by UV or welding arc exposure. Pathophysiology. Corneal insult. Infection, trauma, or chemical exposure damages corneal epithelium. Down arrow. Inflammatory response activation. Release of cytokines and immune cell infiltration causing swelling and pain. Down arrow. Microbial proliferation, if infectious. Pathogens multiply, eroding corneal layers. Down arrow. Tear film disruption. Loss of corneal clarity and increased sensitivity. Down arrow. Corneal ulceration or scarring. Deep tissue damage leading to opacity. Down arrow. Potential perforation or vision loss. Severe cases compromise corneal integrity. Clinical manifestations. Severe eye pain or discomfort. Redness and inflammation of the eye. Excessive tearing or discharge, purulent in bacterial cases. Foreign body sensation. Blurred or reduced vision. Sensitivity to light, photophobia. White or gray spot on the cornea, visible ulcer. Eyelid swelling or spasms. Difficulty opening the eye. Diagnostic evaluation. History taking. Onset, duration, and severity of symptoms. Recent eye trauma, contact lens use, or water exposure. Associated conditions, example herpes outbreaks, autoimmune diseases. Physical examination. Slit lamp examination to identify corneal opacity, ulcers, or infiltrates. Fluorescein staining to detect epithelial defects or ulcers. Visual acuity testing to assess vision loss. Laboratory and imaging tests. Corneal scraping culture, bacteria, fungi, or parasites. Polymerase chain reaction, PCR, for viral DNA. Confocal microscopy for acanthamoeba detection. Medical management. Pharmacological management. Antibiotic drops, fluoroquinolones, example moxifloxacin, for bacterial keratitis. Antiviral drops/oral meds, ganciclovir or acyclovir for viral keratitis. Antifungal drops, natamycin or amphotericin B for fungal keratitis. Antiparasitic therapy, polyhexamethylene biguanide, PHMB, for acanthamoeba. Cycloplegic drops, atropine to relieve pain and spasms. Steroids, cautious use post-infection control to reduce scarring. Surgical management. Corneal debridement, removal of infected tissue in resistant cases. Corneal transplant, keratoplasty for perforation or severe scarring. Amniotic membrane grafting, to promote healing in non-healing ulcers. Dietary management. Vitamin A-rich foods, example carrots, spinach to support corneal repair. Hydration, to maintain tear production. Anti-inflammatory diet, example omega-3s from fish to reduce systemic inflammation. Nursing management. Risk for infection related to microbial invasion or contact lens misuse. Interventions. Educate on proper contact lens hygiene, example no tap water, regular replacement. Administer prescribed antimicrobial drops as per schedule. Teach hand washing before touching eyes or applying medications. Advise against eye rubbing to prevent spread of infection. Monitor for worsening discharge or redness and report promptly. Risk for vision impairment related to corneal damage. Interventions. Assess visual acuity regularly and document changes. Educate on adhering to treatment to prevent scarring. Encourage follow-up with an ophthalmologist for ongoing evaluation. Teach recognition of symptoms like sudden vision loss. Recommend protective eyewear during healing. Impaired comfort related to pain and photophobia. Interventions. Administer cycloplegic drops to reduce pain and spasms. Suggest dark glasses or dim lighting to ease photophobia. Apply cool compresses to alleviate discomfort. Encourage rest with eyes closed to reduce irritation. Provide analgesics if prescribed for severe pain. Risk for corneal perforation related to untreated or severe keratitis. Interventions. Monitor for signs of perforation, example sudden pain increase, vision drop. Educate on the urgency of reporting worsening symptoms. Prepare patient for potential surgical intervention if indicated. Ensure strict adherence to antimicrobial therapy. Advise against activities that could further injure the eye. Disturbed body image related to visible corneal opacity or redness. Interventions. Reassure the patient about treatment efficacy and potential recovery. Discuss cosmetic options like tinted lenses post-healing if scarring persists. Offer emotional support for anxiety about eye appearance. Encourage open communication about self-image concerns. Refer to counseling if distress impacts quality of life. Prevention. Contact lens care, clean and replace lenses as directed, avoid sleeping in them. Eye protection, wear goggles during risky activities, example swimming, welding. Hygiene, wash hands before touching eyes or applying drops. Avoid trauma, use caution with sharp objects near eyes. Regular checkups, screen for early signs in at-risk groups, example lens wearers. UV protection, wear sunglasses to prevent photokeratitis. Complications. Corneal scarring or opacity. Permanent vision loss. corneal perforation or thinning, chronic pain or recurrent infections, secondary glaucoma, from inflammation, endophthalmitis, rare, severe spread of infection. Conclusion: keratitis is a serious corneal condition with diverse causes, ranging from infections to trauma. Its potential to cause vision loss highlights the importance of early detection, aggressive treatment, and preventive measures. Through proper management combining medical, surgical, and lifestyle approaches, patients can achieve favorable outcomes and preserve ocular function. Education and awareness remain vital, especially for high-risk groups like contact lens users.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.